I'll talk about the benefit of intensive lipid-lowering therapy and safety about Pitavastatin and Ezetimibe combination therapy. The contents of the presentations are as follows. Let's take a look at prevalence of dyslipidemia and the importance of the treatment. Hypercholesterolemia is steadily increasing in Korean adults. Nearly 1 out of 4 adults has a hypercholesterolemia in 2022. People with obesity, diabetes, and hypertension has much higher risk of dyslipidemia than those without. 1/3 of adults with hypercholesterolemia are unaware of their condition. More than half of adults with hypercholesterolemia take medications. 87% of lipid-lowering drug users maintain blood cholesterol level below 200. As you know, dyslipidemia and along with hypertension and diabetes is a major risk factor for coronary heart disease. Higher total cholesterol or LDL cholesterol increase hospitalization and mortality from cardiovascular disease. Let's review this case. A 62-year-old male patient with a history of uncontrolled diabetes and hypertension and LDL cholesterol level of 101. Presented to the emergency room due to chest pain. Coronary angiography revealed severe coronary artery stenosis. In patients with uncontrolled diabetes, cardiovascular event occurred even with a LDL cholesterol level of 101. Let's take a look at this dyslipidemia guideline and treatment. By updating the dyslipidemia guideline, the goals of LDL cholesterol levels have become more intensive. The patient with cardiovascular risk categorized, especially high risk and very high risk groups, should be considered more intensive reduction of LDL cholesterol than before. In 2019 ES guideline, it is recommended that target LDL cholesterol be established a low threshold in patients with diabetes and concomitant major cardiovascular disease. The Korea guideline recommended the higher cardiovascular risk need to lower LDL cholesterol level for treatment goal, and similarly recommended to LDL cholesterol target goal of less than 55 with coronary heart disease and diabetes with target organ damage, aligned with European guideline. Now we need to consider applying the lower target of level of LDL cholesterol and a goal approach to LDL cholesterol management and treatment goals are tailored to the total cardiovascular risk level. In Korea guideline, it is recommended to employ maximally tolerated statin therapy until the target LDL cholesterol level is attained. The target is not achieved. The addition of Ezetimibe is advised. Let's take a look at statin monotherapy. Statins are cornerstone of the therapy among LDL cholesterol lowering drugs. In clinical studies on primary and secondary prevention of cardiovascular disease with statin, lower LDL cholesterol levels are associated with greater reduction of the cardiovascular event. Even with the aggressive reduction of the LDL cholesterol, the risk of cardiovascular events in patients with coronary heart disease remain substantial. Statin can cause adverse effects from long-term use of high-dose statin, including hepatotoxicity, muscle pain, and diabetes. The most common reported adverse events of statin therapy are statin-associated muscle symptom sums. It is difficult to disregard those factors. Concerns about the side effect was the leading reason for statin refusal or discontinuation. Let's review the case. A 66-year-old female patient was taking moderate intense statin. 1 month later, she visited a neurology department due to leg pain, and elevated muscle enzymes were found. The patient had no choice but to discontinue the medication. And this 56-year-old male patient with hypertension, hyperlipidemia, and ex-smoker previously underwent PCI with multiple stent restenosis. stent insertion. Although lipid-lowering medication was recommended, he discontinued it on his own due to muscle pain. Subsequently, stent restenosis occurred, leading to CABG. Concurrent evidence from RCT and generic studies indicate that statin treatment is associated with a modest increased risk of new onset diabetes, approximately 1 case per 10 patients per year for exposure by this mechanism. Therefore, it is needed to have statin-ezetimibe combination in order to overcome such obstacle. Statin and ezetimibe work together to lower cholesterol, but they do so in different ways. In combination, statin reduces the cholesterol produced by the liver, while ezetimibe selective cholesterol absorption inhibitor reduces the small intestinal enterocyte uptake and absorption of cholesterol by binding to MPC1L1, which keeps cholesterol in the intestinal lumen for excretion. Doubling of statin dose only shown for the 6% reduction in LDL cholesterol. This is a rule of 6. In comparison, the administration of one ezetimibe 10 mg of ezetimibe result in significant LDL cholesterol reduction compared to the effect of 3-dose statin. Through various studies, the addition of ezetimibe reduced LDL cholesterol result in further reduction of LDL cholesterol level by approximately 25 to 31%. Statin and ezetimibe combination group demonstrate a significantly LDL cholesterol reduction effect compared to the statin monotherapy and statin dose doubling group. According to the IMPROVE-IT study published in New England Journal of Medicine in 2015, combination therapy resulted in mean LDL cholesterol 24% reduction compared to simvastatin monotherapy. In terms of primary endpoint, combination therapy demonstrated a clinical benefit of 6.4% compared to monotherapy. IMPROVE-IT study supports the proposal of ezetimibe should be used second-line therapy on association with statin when the therapeutic goal is not achieved at the maximal tolerated statin dose, and in cases where the statin cannot be prescribed. According to racing trial published in The Lancet in 2022, the combination therapy of moderate intensity statin and ezetimibe was shown to be non-inferior to high-dose statin therapy regarding the primary endpoint over the period of 3 years. In combination group showed superior LDL target achievement rate compared to rosuvastatin monotherapy group at all times of point of 3 years of follow-up. Next, I'll talk about the pitavastatin and ezetimibe combination. Among statin prescription, 92% were in moderate intensity statin. In 75% of patients with ischemic stroke, ischemic heart disease, and heart failure associated with dyslipidemia, lipid levels are effectively managed with moderate intensity statin therapy. Pitavastatin is classified as a moderate intensity statin in the APCIS guideline and is noted in the Korea guideline for achieved LDL cholesterol level reduction of 43%. This study is first clinical trial to compare the outcomes of pitavastatin and atorvastatin to assess the difference. Patient had one more atherosclerotic disease risk factors, including hypercholesterolemia. This study was divided to 2 groups, pitavastatin and atorvastatin. Change of lipid profile were reduced similarly between pitavastatin and atorvastatin group. However, pitavastatin group compared with atorvastatin therapy significantly reduced cardiovascular events. And pitavastatin showed a significant reduction in hsCRP compared to baseline. There is a concern about the new onset diabetes with high intensity statin therapy. Patients without diabetes in particular are concerned about developing diabetes after taking statin. In CAMIL-DM study, AMI patients who have undergone PCI, the cumulative incidence of new onset diabetes was significantly lower in pitavastatin group compared to atorvastatin and rosuvastatin group. The aim of this study is to assess the incidence of diabetes on 14 million newly initiated statin users in Korea. This study was based on real-world clinical data. So comparing the incidence of new onset diabetes in patients at least 108 days after taking statin, including in pitavastatin, atorvastatin, and rosuvastatin. In the result, the risk of new onset diabetes is 28% lower for pitavastatin compared to atorvastatin and rosuvastatin. Finally, I will introduce L0Z. The aim of this L0Z phase 3 trial is to evaluate the efficacy and safety of pitavastatin plus ezetimibe combination therapy in patients with primary hypercholesterolemia compared to pitavastatin monotherapy. Primary endpoint was rate of change of LDL cholesterol at 8 weeks relative to base. At 8 weeks, the L0Z treatment group showed greater reduction in LDL cholesterol level compared to pitavastatin monotherapy group in dosage. L0Z treatment group achieved significantly higher LDL cholesterol target rate compared to pitavastatin monotherapy group. No significant difference in adverse event incidence was observed between two groups. Let's take a look individual case. A 66-year-old woman with a history of statin-induced myalgia took 4 milligrams of pitavastatin, which reduced her LDL cholesterol 43%. She didn't have experience of statin-induced myalgia. And a similar case, but this woman is a 56-7 female, took pitavastatin ezetimibe combination therapy for 10 milligrams per, and which reduced LDL cholesterol more 70%. And last case, a 44-year-old male patient with obesity took pitavastatin ezetimibe for 10 milligrams milligram and took pitavastatin, and which reduced LDL cholesterol by 56 reduction. In summary, America, Europe, and Korea guidelines recommend intensive LDL cholesterol management based on cardiovascular risk. Statin plus ezetimibe combination therapy significantly reduced LDL cholesterol more than increasing the statin dose. Pitavastatin affords strong lipid lowering effect and is safe from the risk of new onset diabetes. The L0Z reduced LDL cholesterol level more effectively than pitavastatin monotherapy with similar adverse event rates. Thank you.